Okay, good evening, essentially South African time, but wherever you are in the world, it may be good morning. And I know there might be one or two Australians who said that they might be joining, and essentially it's 5 a.m. their time. So welcome to everyone. Maybe just to get started, I'd love to just hear from you guys and see where everyone is from. So drop it in the chat and say hi and where you're tuning in from. I want to see where everyone is around the world. Yeah, and maybe how long you've been running, and whether it's menopause is something you're struggling with, or whether you're in perimenopause, or you're just here for the info. So really cool to see. There's a couple of people. I see Kath is in the UK, Daniela's in London. Wow, Samantha's in Calgary. So many. This is going. See Cape Town. Sandy's in Cape Town. This is awesome. There's so many people just logging on. So this is brilliant. I'm waiting for two panel members to log on as well. At the moment, maybe let me cover some house rules in the beginning. I think we're here to essentially talk menopause and perimenopause and running through that and how to really optimize training and life by using training and nutrition and other aspects through this process. There we go. We have one of our panelists who has joined, and I'm sure Barbara will also hit her camera on in a second. So let me get cracking, perhaps with some introductions, and I'm happy for my panelists to have their cameras on, and we can have those on the whole time. Just by way of introduction, I'm going to start with the lady on screen there, Barbara Hannah Grafferman. Barbara, we are very honored to have you with us tonight. Barbara is an award-winning author and journalist. She's written several books on healthy aging and is the founder and editor of the Menopause cheat sheet. And she does this in conjunction with an expert endocrinologist. So really relevant for what we're talking about tonight. She's heavily involved in the National Osteoporosis Foundation in the US. She's received a number of awards from them. And perhaps, not more importantly, but one of the stats I love about Barbara is that Barbara only started running when she was 50. And she's completed essentially 10 marathons, one of which was on Friday, the most recent one ultra marathon, and countless smaller races, all since turning 50. So, Barbara, thank you so much for being here tonight. Really happy to have you. Welcome.
Thank you, Shona. Thank you, everyone from the Coach Parry team, for having this incredible conversation that's so necessary, because menopause is still a taboo, and we've got to break that taboo. So thank you.
Brilliant. Thank you, Barbara. And then somewhat of a familiar face. Welcome back, Doc Pato Zondi. For those of you who weren't on our last webinar, excuse me, I'm just going to read through this a little bit just to tell you about the brilliance that is Doc Pato. She's a well-established sports and exercise medicine physician by trade. She's an avid runner and mountain biker at heart. I always say that she's probably more an avid runner by heart, Doc. The runner sits well within your heart. Her clinical expertise is in injury prevention and management, and these have enabled her to accompany athletes to Olympic Games, Paralympic Games, and the Commonwealth Games within South Africa. Doc Zondi holds numerous leadership, advisory, and governance positions. And this is one of my favorite things, and I learned this recently, is that in 2017, she was awarded with a Ministerial Recognition Award by the South African government for her contribution to advancing sports in South Africa. So welcome, Doc. Awesome to have you here with us as well.
Thanks,
welcome
back.
It's
great to be here. And I'm really looking forward to the conversation.
Awesome. And maybe just by way of introduction, and I'll introduce myself. My name is Shona Hendricks, and I'm essentially the head of athlete success at Coach Parry. I'm a qualified sports scientist and qualified with an MBA, as well as a certified strength and conditioning coach through a certification in the USA. But again, the focus here is around menopause and perimenopause, and really just opening up this conversation. So great. Thank you so much, everyone, for joining, and keep the chats going on the side here. Just as an FYI, we want to receive questions. We will try and answer as many questions as we can through the presentation. Just so you know, we want to be quite sort of adherent to your time and respectful of that. So we're looking to go for around 45 to 50 minutes from a presentation, taking a couple of questions, and then we'll definitely have a bit of a Q&A at the end. So I'm going to get started. Essentially, let's get going with what is menopause, right? So we use the colloquial term of menopause, but really there's a differentiation between perimenopause and menopause. So perimenopause is this period or this transition period from when you start getting the initial symptoms of menopause and all the way up until you actually stop having your period. For a lot of women, this is normally around 4 to 5 years, but really, we've read that it can last up to 10 years. And it's the time at which where your periods become quite irregular. Those symptoms tend to start flaring up and showing up, and this is due to all of those hormonal fluctuations. Essentially, what is menopause? And again, so we speak about menopause, but menopause is really this one specific point in time. Okay, so it's this point in time where you haven't had your period for 12 months. The average age for most women is around 51 years, but that can sort of deviate between 56 or maybe even 46 years old. And again, premature menopause can happen as early as 40 to 45 years old. I won't go into details around how this is really determined, but for the most part, Doc, and you might touch on it later, but for the most part, physicians tend to use a bit of a symptomatic score as opposed to blood tests to define this point in time. And then from post-menopause, which essentially we describe as menopause, right, as the colloquial term, this is really the stage at which menopause is complete and your menstrual cycle has stopped. This is where your hormones tend to flatline, and really where those symptoms and issues that you've been experiencing perhaps get a little bit highlighted, and really I think in the world view of the word, it's sort of coming out that your life is now done, and we want to change that. Your symptoms maybe subside a little bit, and I think Brad's going to pop up a poll because I'm quite interested to hear with everyone who's logged on, where you are in your sort of phases. Are you essentially perimenopausal? Are you on that point of menopause, or are you postmenopausal? We're quite keen to hear where everyone is at, and to my panel members, you can have a look at those as they're coming up. And so this postmenopause phase is essentially described as what will now be the biological state for the rest of your life. Okay, and all the textbooks are saying that this is your biological state for the rest of your life. And to be honest, I don't quite like how that's worded. And so I want to say that yes, that's true. Biologically, this is what's going to be your biological state. But in my chats with Barbara, and it's been quite interesting, as Barbara has a statement, yeah, it's very true, but it's never too late and it's never too early to be doing things to make sure that is not your status quo. And we can use things, and I've pointed them out there, training and nutrition to try and mitigate perhaps some of those symptoms. Barbara, and perhaps I can bring you in here because I'd love to hear and tell everyone a little bit about your personal story and how you've essentially utilized these two components to be where you are today.
Right. Again, I want to just say that menopause is really something that people don't like to talk about, not with themselves, not with their best girlfriends, not with certainly their sexual partners or even their doctors. And there are a lot of reasons for that. I've discovered after doing research and talking to women and people who read my books and the like, that people I'm connected to, that it signifies aging. And who in the world wants to talk about aging? Not that many people. And my own experience with menopause is that I didn't know anything about it. And that is typical, that is common. We don't know enough about it because we don't focus on it. And even our doctors don't want to discuss it with us. Also because of the way the whole medical system is set up, there's not a lot of time to spend with patients. So they're not focusing on this very important life experience. And I want to stress that. This is not a disease that needs to be cured. It is something that happens to literally all women. Now, it's universal, but it's personal because, as Shona pointed out, it happens at different stages in one's life. I happen to have been about 50 when I was finished with menopause. My own quick experience is a story, is that I did go through menopause. Lucky for me, my symptoms were really quite manageable. Yes, I had hot flashes. Yes, I had the sleepless nights. Yes, my husband would attest and my children would say that my mood swings were there. But they were manageable. So I was, I guess, one of the lucky ones. However, I didn't really realize what the bigger picture was. What was happening inside of my body. All those symptoms I just mentioned are considered temporary. Now, yes, they may last longer than one might like, but they are temporary, associated with menopause. However, there are changes that are going on inside our bodies, inside and out, head to toe, I like to say, that I never imagined were actually happening. For example, just as I was coming out of menopause, I was walking my dog and really not feeling very good about myself because had what I called the umpies. I was feeling a little frumpy, a little lumpy, a little bumpy, and very grumpy about the whole thing. and not really doing anything good for myself. I wasn't at that point running, working out really enough, not sleeping enough, taking care of everybody else because that's what women do. And I took I took my dog for a walk and tripped on my own 2 feet, don't know how, and ended up in the ER with a broken arm. And why was that? It's because, well, I had gone through menopause, estrogen levels dropped, which we'll discuss, I know, in greater detail. And of course, my bones got thinner and weaker as a result. I had no idea that was taking place. And I think a lot of women still, and this was almost 14 years ago, and a lot of women still don't understand what is happening to their bodies, sometimes permanently, as they go through menopause. So that was my own experience. So again, it's a very long story, but I'll shorten it as best I can. It was at that point I decided, okay, so is this what getting older is all about? Am I going to put that proverbial blanket over my head and just let it all happen? Or am I going to take control, figure it out, talk to some experts, get a plan, super important, everyone, that I could mitigate as many of these symptoms as possible and continue to have a very good life, a productive life, a good life, filled with good health and well-being. And that's, well, I think you probably know the answer. That's the direction I chose. And that's what inspired me to write my first book about healthy aging. And then I've written another one since then. But I have to tell you that with all the research I've been doing since then, in writing my books and everything I do and the talks I give, I now realize that this is not about aging. This is about menopause. And I like to say now that all roads lead to menopause, because everything that happens to women, I'm talking about now, of course, to women as we go on in life, can all be connected back to menopause and the drops in estrogen. That's my quick story.
Yeah. Well, Barbara, I mean, I love that. I mean, you've gone on to, I think you might have just finished more marathons than me, if I'm not mistaken. Now I haven't actually counted mine, but if you're on 10 with your most recent one, you know, I mean, your life is just, maybe before we move on, just quickly, just comment on how that has changed your world. You know, now you don't fall over from walking your dog and land up with a broken wrist. I mean, your quality of life, I guess, is dramatically improved. Correct?
Absolutely. And how that happened was, as I was going through all of this, I had the cast on my arm, feeling really not very good about myself, but starting to get on track and do the research and trying to figure out my own personal program. I read an article about Jeff Galloway. Now, Coach Parry is a big fan of Jeff Galloway. For you, those of you who don't know who he is, he's a former Olympian. He's now a man in his 70s, and he believes in the run-walk program, and he believes anybody can run. If you can walk, you can run. Basically, that's his philosophy. And so I started running and walking with that approach. And I must tell you, that has completely changed my life in every possible way. Amazing. And I believe that once you have your foundation healthy habit, as I call it, this is like my foundation healthy habit, other healthy habits happened. I wanted to be a faster runner, so I started eating better. I wanted to make sure my bones were maintained, that I didn't lose bone density. So I changed, again, my nutrition. I tweaked. It wasn't major overhauls, everyone. Yeah. Don't get afraid. It was tweaking. And I believe that we all need to tweak, like reassess where we are every few years, certainly every decade, and make the tweaks with what we eat, how we move our bodies, the nutrients that we're getting that we may need more of, the calories that we're getting, we may need less of those, which we do as we get older. But anyway, so that's what started me on my running. And then of course, I have two daughters, both in their 20s, and I believe, I hope I'm setting a very good example for them, having them focus on all of these things now while they're in their 20s, which I think is important. So when they get to be my age, they'll be much further ahead. And one of them said, I want to hold up a sign one day, Mom, that says, "Go, Mom, go." And you know, run the New York City Marathon, which goes right past our apartment. That was my very first marathon, the New York City Marathon. Very special. And I'm proud to say that with good training and now training with the Coach Parry team, I have gotten faster and stronger with each marathon.
Yep. No, and I mean, that's excellence. And one of the things I want to maybe focus on from here is the stigma that comes from menopause. And we actually probably should have done this as the poll now that I think about it. You know, now we're looking at like 30, literally a third sitting perimenopause, postmenopause, or some don't really even know. But the poll we probably should have done, and I actually asked my fellow colleagues this today, is if you think of menopause, what comes to mind? And the words that came to mind were old, hysterical, emotional, and actually we probably should have put that up. But I just want to touch on this, and I don't want to spend a lot of time because we want to focus on the good stuff around training and nutrition and how to mitigate a lot of these things. But just have a look at this timeline, and you know, this is essentially how menopause has been defined since the 1600s all the way. And I mean, there's things there like closely linking menopause to insanity, being put in asylums or having forced hysterectomies, or, you know, Freud perhaps looking at it and arguing that it was a neurosis. You know, but what's astounding to me here is that essentially in 1821, it's the first time that menopause is announced in a medical journal. And yet, you know, however many hundreds of years later, we still, I mean, that's nearly 200 years later. My maths is bad, but somewhere near around 200 years that
it's
we're
so
still
crazy.
Kind of,
it's so
yeah,
crazy.
exactly.
Jonah,
We're still not really getting that.
I also want to point out that, I mean, just look at lifespan, how that has changed, right? So when you think about it, women's lifespan was so much smaller 150 years ago.
Yes.
You know, so many women died in childbirth. We just didn't live this long to actually experience menopause or experience menopause for any length of time. So it was almost like this, in some weird ways, is still kind of a newish you know, area of exploration for us, and we are still learning about menopause. I mean, do not think otherwise. This is still being explored because, as we know, and very unfortunately, so much of medical dollars and energy and effort is often put behind I don't want to say men's issues, but you know, we're still often viewed as smaller men. Like we know with heart disease, that was a major thing, that there were no studies being done about women and heart disease. And do you know, this to me is incredible, that brain health, which is a huge area of exploration. I wish I could go back and, you know, go back to medical school, and that's what I would like to do, everyone, just so you know. And just in case you were wondering. And where brain health, again, we're still focused on men's brains, and it's only recently that we're really studying not only women's brains, but how women's brains are affected by menopause. And again, menopause meaning the severe drop in estrogen levels. Incredible.
Yeah, exactly. Sorry, I think that was me going a little bit ahead there, but no, spot on, Barbara. And I mean, that's exactly it. And I think, you know, that's leading into the next point. We've constantly, oh gosh, sorry, things are going mad down there. But the language that we use essentially shapes perceptions of these things. And if we think about the word period, you know, it's this curse or this time of the month, or you know, always hormonal or temperamental. And the same with menopause. And you said it earlier when you were telling your story around it's this change and how it should be viewed as something that's positive. And I want us to move more towards that this is a natural transition. We need to stop viewing it as something that we're losing. You know, this hormone deficiency, we're losing something, and rather talk about it more and learn from each other, and then find the modalities that we can use to essentially empower women and to mitigate all these symptoms. So with all of this in mind, maybe Doc, I'm going to bring you in here, and you can bring in all the neuro and the brain and all the science stuff, and essentially give us the science behind menopause. And I'll
Thanks,
hand over
Jonah.
to you.
It's really great to be with the Coach Perry team again tonight. And I love that we are having these candid conversations about topics that are entirely relevant to female athletes. Like you're saying, Barbara, it's bizarre that we're all going there. All roads lead to menopause if you're female. But it's bizarre that we're only really starting to unpack it in a way that's practical, relevant, meaningful in these late years, given that we've been going through all our lives. So essentially in my time with you, as we're having this conversation, I'd really like to focus on take you through three areas. I would like to start by talking through the physiology so that we all understand the hormone changes that occur during menopause and how and why the various symptoms occur. So Barbara mentioned that, all right, she experienced the symptoms, they weren't that bad, but she actually didn't know what was happening to the body. And I'd like to just take you through that very briefly. I would then like to touch on how to manage symptoms, but I'm really going to be brief here because this isn't about the different kinds of therapies that are available to you, but more about, you know, how menopause, perimenopause may or may not impact your running and what we can do about it. And so that's where I'd like to spend my time really on that third area and speak to how and why menopause does affect running. Let's start by understanding then the changes in hormones. Now, simplistically, there are three phases in a woman's reproductive cycle. So we speak about the pre-reproductive years, and that's obviously pre-puberty. We speak about the reproductive years, and those are the years that we menstruate. And then we speak about post-reproductive years, and that's entirely the topic of our conversation tonight. The differences in each stage relate primarily to the levels of female sex hormones. Now, when we discuss reproductive health in women, there are four main hormones that are referred to. There is progesterone and estrogen or estradiol, and those are the most important sex hormones for sexual and reproductive development in women. These are represented in the illustration that you see here on your screen, progesterone in green and the estradiol, which we commonly refer to as estrogen, in purple. The other two hormones that aren't in this diagram because they're not entirely relevant for our conversation today are what we call LH and FSH, so luteinizing hormone and follicular stimulating hormone. And these hormones are particularly important in our reproductive years because they stimulate follicular growth and ovulation, right? So they're important for your menstrual cycle and getting it regularly every month. But what's important to note, I suppose, is that with menopause, the levels of estrogen and progesterone drop such that they can't sustain ovulation, they can't sustain menstruation, and they can't sustain uterine health, and therefore a woman stops ovulating, a woman no longer gets her period, and of course, they're no longer at risk of falling pregnant. I say risk as if it's a bad thing, but in the context of reproductive health, that's essentially the end point, right? You cannot fall pregnant anymore. And so as Shona described in the intro, and as Barbara's emphasized in her telling her story, this is all a natural part of life in a female, a natural part of aging, usually occurs in your 40s or 50s, but for other reasons, it might occur earlier. I was reading through some of the comments and I noticed that there was a Tracy who mentions that she had a surgical menopause. She had a hysterectomy and had both of her ovaries removed. And this is very much a cause of early menopause, or one might undergo menopause if they have undergone chemotherapy or radiotherapy, or if a woman suffers from a condition called primary ovarian insufficiency. And that's really when your ovaries aren't able to produce the normal levels of reproductive hormones. And that can be because of genetic factors, it could be because of autoimmune disease. Specifically, maybe to answer your question, Tracy, while we're here, absolutely. If you undergo surgical menopause, the period of the fluctuating hormones obviously doesn't take place because it happens very suddenly. Your ovaries are removed, therefore you stop producing estrogen and progesterone quite suddenly, at least your main sources of production. And therefore, while we sometimes speak about perimenopause lasting up to 5 years, in the case of surgical hysterectomy or surgical menopause, it might take place very suddenly and very quickly, and that transition doesn't take place over such a long period of time. So the next slide then illustrates the role of estrogen and its relationship to various systems. We commonly speak about estrogen in the context of reproductive health, but it's quite important to note that estradiol is also essential to neuronal health, and it influences other physiological processes like bone health, like glucose homeostasis, like metabolism. And again, Barbara alluded to the bone health issues that she experienced, unbeknowing that it was actually related to menopause. So when
Doc, I mean, sorry, there's a comment that's come through from Lisa, and Lisa's actually said, I would take my period back for the rest of my life just to have the estrogen back. I hate the loss of muscle mass, skin tone, and fat in new places without weight gain. So absolutely. I mean, spot on. Essentially, that's estrogen and the lack thereof. That's put on. But I love that comment.
Absolutely. We often think of it only in the context of having our period and reproductive health, and we don't understand the impact that it has on other processes and systems throughout the body. And really, that's why when estrogen fluctuates and then plummets post-menopause, what you see is that red line, all those symptoms, all those systems are affected. All those symptoms then start to appear. So there's an impact on mental health. There's an impact on cognitive function and mood. There is an impact on the cardiovascular system with an increased risk for certain cardiovascular disease. There's an impact on your metabolism and insulin sensitivity. And so we'll speak a little bit about weight gain. There's an impact on the urogenital system, incontinence, bleeding, dry vagina. And of course, there's an impact on bone health. And we've spoken about this, which increases the risk of osteoporosis or weakens your bone density and then puts you at risk of fractures. So all of these symptoms then start to appear, and these signs and symptoms may appear during the perimenopause period. And certainly, of course, when you're now menopausal and then postmenopausal, and those estrogen levels have plummeted and dropped.
Yeah, we did. I only really talked about the bone density issue that I had. And by the way, with running, I started running not only to lose weight, but also to keep my lower body's bones dense. And that really has worked now. Like I said, I had low bone density according to my first bone density test after I broke my arm. But by just doing some of these very simple, or making these simple lifestyle changes, I was able to, and continue to be able to, maintain my bone density so far. We don't know what will happen in the future. But also, I started to have heart palpitations. So, that's also very common. The dryness factor, head to toe, inside and out, many different places, including dry eyes. These are just things that women, I wish I had known about this, is point. And that's one of the things we really want to share with everyone today who has not yet gone through or is just starting to go through. For those of you who, like me, postmenopausal, who have gone through so much of this, you're shaking your head along with me right now.
Absolutely, and there's a couple of our guests actually who are sort of testifying to the symptoms. Lisa complaining that she's also experienced muscle mass loss. Jasmina saying she's tired of the mood swings, so definitely relating to that, and the headaches as well. So certainly people who can relate to the symptoms that we have described in the perimenopausal and certainly postmenopausal period. So very briefly then on the symptoms. Now, importantly, as all three of us have said, menopause in itself is a natural process, and so it doesn't require any medical treatment. But the treatment focuses on relieving symptoms, because this is what bothers women who are going through perimenopause and menopause. So the treatment that is discussed in the context of menopause or perimenopause is really about relieving signs and symptoms. It's about slowing down the process of bone loss, and also about preventing or managing any other age-related chronic conditions. Most women will report that, on the hot flashes, they'll report on mood disturbances and insomnia. I mean, I'm just sort of clustering the three main symptoms, but we've discussed all the other ones. And so these treatment modalities that you see that I've listed here mainly address these three areas of symptoms, all right? I've listed various pharmaceutical interventions and various alternative medical interventions that address these three areas of symptoms, like I've said, but I'm not going to go into the details of each of them because today isn't about going into each of them. Mm-hmm. If you would like advice about which to use, you would need to consult your own medical doctor who would take a history, they would examine you, they would assess your risks, and then of course they would discuss a plan that's best suited to your overall clinical needs. There are also a number of non-medical interventions that one could use and that would be helpful in managing these symptoms. And of course, that depends on the severity of the symptoms. And again, I've listed some of these, what you can do to address or decrease the discomfort caused by the hot flashes, what you might want to do for the dryness. I know Barbara described top to toe here. I've only sort of spoken to issues related to vaginal discomfort and urinary incontinence. Kegel exercise has been really important. We all know this during pregnancy. Just to remind you, you could do them while you're sitting here if you want to, just so at least you're doing it now.
Right now. We might be doing it.
And then, of course, certain non-medical interventions, many non-medical interventions that you can use to address the sleep disturbances, the mood disturbances, and I haven't, of course, here listed diets, but exercise being a really important one. But as I've said,
Doc, can I raise a question there? Maricel's asking, how does menopause affect the sleep process? What is actually happening that is causing that?
There's a number of things that are happening, Marilise, but one of the main effects of the decrease in estrogen is that it influences melatonin. So it impairs the production of melatonin. Melatonin is responsible for making you drift off to sleep, in part because it helps drop your core body temperature. So when that doesn't happen, essentially, your body responds by making you perspire, but because menopause or during perimenopause, you're also having issues with your hypothalamus, and that's your temperature regulation system, you tend to overshoot. So you'll end up over-perspiring, and then you'll end up with chills, and then your body will heat up, and then you'll overshoot. So it's a vicious cycle. But essentially, that's one of the reasons that your sleep is disturbed, because of that influence on melatonin.
Great, thanks, Doc.
So as I said,
too, of all the research that I've been, I just wanted to say, of all the research that I've been doing these past few years, is that exercise, and you did mention it, exercise really is critical as a non-medical intervention for almost all of the symptoms, as well as some of the more chronic ones like bone density, heart health, brain health, as we now know for sure. But it really does help to mitigate some of the hot flashes. And certainly if you tire yourself out a little bit, I think sleep will come a little easier at night, even if you are a little
Absolutely. In the world of sport and exercise medicine, which is my world, we say exercise is medicine. It's that one thing that can treat so many symptoms, signs, illnesses, help manage diseases. And in this particular case, as you correctly say, Barbara, exercise is really effective in treating many of the symptoms related to menopause, including sleep. So next, really, what I'd like to focus the next and perhaps the final part of my conversation on before we take more questions, or as we take more questions, is really speaking to how practically this phase of life may influence your running, and perhaps even what you can do to address some of these issues. So first up, really, some practical considerations. So, in terms of how it may influence your running, here's what commonly comes up from the many females that I have consulted who are navigating their way through menopause but wants to consistently remain exercising and training, which is great. Feeling extremely hot very quickly, and then having difficulty cooling down. Now, the backstory behind this is that normally your blood vessels will expand as you warm up, and that sends blood closer to your skin, all right? So that cools you down. But the lower estrogen levels blunt this response and trap more heat inside your core, essentially. So this, along with changes to your brain's thermostats, that hypothalamus that I mentioned, is likely to contribute to this particular presentation. So this heating up very quickly, and then after exercise, finding it very difficult to cool down. The Second place of impact might relate to sleep disturbances, and we've mentioned this. So again, the lower levels of estrogen and progesterone, they decrease the production of melatonin. I've mentioned this, which means that you would find it difficult to sleep. Your core temperature doesn't drop, and then your body tries to cool you down by pumping out perspiration, but you overshoot and you basically enter into the cycle of sweating, then waking up chilled and sticky, heating up, sweating, waking up chilled and sticky, and it's really uncomfortable. And then finally, another common, I won't say finally, but another common, relatively common complaint might be dizziness after a run. And again, underlying this fact relates to the impact of estrogen, or the fluctuation or decrease in estrogen, on the cardiovascular integrity, right? And so blood vessels, again, take longer to expand at the start of exercise and longer to contract after exercise. And this then may cause your blood pressure to drop and the subsequent lightheadedness that you might feel. Now, it's important for me to just note here that there are other medical reasons for being lightheaded during exercise or after exercise. And so if this is something that's bothering you, it's important that you obviously consult a physician just to make sure that it isn't anything more sinister. But I just want to stop there, Barbara, and ask if any of this was your experience, and perhaps even the audience, if any of this has been your experience.
Definitely, yes. But again, I started running after I went through menopause. So in my case, it might be a little bit different, my experience a little bit different than some of those tuning in today who have been running and are now experiencing perimenopause or menopausal symptoms. For me, I embraced running and then strength training, which we haven't really talked about yet, how important that is, and especially shown as exercise classes and tapes, must do, is so critical. And it was a critical component for me as I was entering my post-menopausal life. And I embraced it wholeheartedly. And so at that point, I was really such a slow runner. I mean, I'm still relatively slow, but I was a slow runner. So I don't know if I ever had of these major overheating experiences like you've been describing here. But I did find that there were some symptoms that lingered after I had kind of officially gone through menopause. And for sure, and I can say this not only based on the research I've been doing for a number of years, but also my own personal experience, that exercise, especially vigorous exercise, where your heart rate really gets up there, really helped to mitigate a lot of these symptoms for me. And I know that. And it also helped me to sleep better. And again, as I said earlier, because I was doing this healthy habit and had embraced this healthy foundation habit into my life, so many others followed suit as a result. My eating, my sleeping better, and making sleep a priority, by the way. This wasn't that my sleep was better. I was actually focused on making sleep a priority, which is something women don't often
Sleep
do.
seemingly being a significant issue, even amongst the participants here. Hillary noticing that she has sleep issues and commenting on the fatigue the next day because of the sleep disturbances. Sandra also commenting on the same challenges, and Tracy as well, speaking about how, you know, I am having sleep issues, and the next day I wake up and I'm feeling tired and sluggish, and this is the way in which it can practically impact your training. Shona might speak to some of the things that you can do, some of the ways in which you might modify your training in order to accommodate for this tiredness after a race this night. Just moving on then. So again, I want to just comment on 3 common questions that have come up with by women going through these changes. The first one is it the beginning of the end? Will I never be faster than I am now? And luckily there, Barbara is shaking her head saying, no, in fact, I started running after I hit menopause.
No.
And in fact, yeah.
No, and goodness, holy moly, I hope that for women who are perimenopausal or not even there yet, I hope we're not scaring you off, because do not be afraid of this. Is nothing to be afraid of. We are just putting it all out there so that you understand and are empowered to take action. And again, as Shona said before, the sooner the better, you know, the earlier the better. but it's never, never too late. And that's where
Yeah.
I feel I'm a walking, living, breathing example of that. I was kind of late. I had no idea what was going on. And then finally it happened, and there I was like, what? And took action then. And, you know, it's working for me. I'll be 64 in December, running another marathon in 2 weeks. You know, I feel good. I'm productive. And my goal right now, and this should be the goal of every single one of you, listen, if you take away nothing else, please take away this. You want to live a life where you're independent and mobile for as long as possible. Think about that. I have a mother who right now is sitting in an assisted living home, no longer living in her own house because she fell and broke her hip 3 years ago because of osteoporosis. And it changed her life, and it really changed my life too in many respects. You don't want that, everyone. You don't want that. And the drop in estrogen is making your bones weaker and thinner. Make no bones about it.
So,
sorry.
Well, there we go.
And in fact, Pam Hart, one of the participants as well, commenting, she's 73 years old, 20 years post-menopause, saying her running has gotten better and better. So there's your answer, ladies, is that no, it doesn't necessarily mean that your fastest days are behind you. There's a lot of factors, but really importantly, if you train for the phase that you're in now and you are smart about how you train, it doesn't have to be the end of your fastest days. Let me move on so that we don't take up Shona's time right now, right? The next question or comment that often comes up really relates to injury. And so the question, and we've spoken about the impact on musculoskeletal health, and bone health, and the concern becomes, am I at higher risk of injury now that I am peri or postmenopausal? And there's two factors to consider here when it comes to physiology. The first one is that when your estrogen levels drop during menopause, inflammation can increase, and this may increase the risk of osteoarthritis, which can result in painful joints and maybe even painful muscles. We also know that a reduction in estrogen does reduce the elasticity of ligaments and tendons. So if you don't adapt your training appropriately, then yes, there is a theoretical risk that you could increase your injury. The key, though, is that you can decrease or avoid this risk of injury if you train correctly. So yeah, I'm setting the stage here for you, Shona, if you train correctly. And that's really important.
You're doing a good job here, Doc. I feel like you can carry on.
And lastly, before Shona says that I entirely stole the show, there have been a few comments about weight management, and obviously it's a big concern amongst many women. The challenges of just maintaining a healthy weight, healthy being the operative word, and many women going, I'm beyond wanting to lose weight at this point in my life. I just want to maintain the weight that I have and not gain weight. And there's two factors to consider in response to this. We know that estrogen influences insulin sensitivity, and changes during your menopause make you more sensitive to carbohydrates. In addition to this, with age, we've spoken about a loss of muscle mass, and your metabolism naturally slows down because of a whole lot of other sort of hormonal and endocrinological reasons. And so this does affect weight management. Practically then, if you don't change anything, so in other words, if you don't change what you eat, and if you don't change how you exercise, then yes, you probably will lose or gain weight because of these natural physiological changes that are taking place, slow down metabolism, and so on and so forth. You also want to be more mindful then, obviously, about what you eat. So the quality and the quantity of what you eat. And obviously, then you can be smart about energy output, right? So we always say that weight gain is a simple equation. It's, energy in versus energy out. If you want to lose weight, you need to, spend more energy than you're putting in. If you want to gain weight, you need to consume or collect more energy than you're obviously spending. And so that becomes really important. The quality of food that you eat, you want to eat food that will promote health, so that's a balanced diet, and you want to ensure adequate intake of certain micro and macronutrients that will help build muscle and facilitate recovery. So I think I'm gonna stop there, Shona, so that we can sort of continue the discussion with more comments, perhaps from our audience, and sharing their own experiences, and maybe address the questions that are relevant and come up as people ask questions and as we then continue the conversation.
And one thing I just want to point out too is that I said it before about every couple of years, I think we all need to reassess where we are in our lives and really look at what we're eating, how we're working out, the nutrients that we're getting, and really everything, and just reassess. And even if it's in partnership with a healthcare provider or a nutritionist, or or any other expert that you feel is required to be on your team, and then make those tweaks. I know I do that regularly because we are works in progress. Our bodies are constantly changing throughout our lives, and so we need to change our routines accordingly.
And just to that last point, and Shona's going to step into the nutrition conversation right now. You're mentioning that you find it very hard to lose weight. You've put on weight post-menopause, but you're eating the same. And I think I've alluded to that, right? And said there are changes that are happening physiologically. And so once you hit perimenopause or post-menopause, you can't do things the same. Otherwise, your body will naturally hold on to sort of body fat, and you will gain weight despite the fact that you're eating the same and maybe even running the same. Something does need to change. I'll let Shona continue with that.
Yeah, let's just be cognizant of everyone's time, and we do want to answer as many questions as we can at the end. So let me get through what I think is the really, really fun, important stuff, which is the strength and nutrition. And again, I think we're just sort of saying here that essentially with the perimenopause phase, I mean, this is a critical time for interventions. Maybe not to exacerbate this point, but the changes happen post-menopause are age-related, and while they're not impossible to change, they are a little bit harder. But perimenopause, it's hormonally driven, and like the doc has alluded to, and Barbara, is that we can do certain things to perhaps modulate that hormone flux and with these interventions. So that's what we're going to get stuck into now. And there's special considerations that we at Coach Perry really regard as important. But we need an entire whole webinar to go through all 5 of these. So for today's purposes, I really just want to focus on strength training and nutrition. Recovery obviously plays a massive role in this, and so does your pacing and your intensity of when you're running, because that ties in with a little bit of the weight gain and obviously your consistency to reach the goals that you have. But for today's purposes, strength training and nutrition. And now we've said this, it's really, really important for body composition, lean muscle mass, and bone mineral density to do some strength training. And so I don't want to get into too much of the science, but it's really important that you understand why this is. And there's 3 aspects really of strength training that we need to consider for this group essentially. And there's heavy resistance training, which is essentially as low reps and heavy load. And I know there's always this concern that you're going to bulk up, but essentially we need to have that strength and the load on the bones, because if you are just a runner, we need a multi-directional force essentially happening on those bones to create that, to assist with the bone mineral density. So I'm getting into my next slide already. I'll focus on the high intensity interval training, and Barbara has alluded to this, that working at that higher intensity is really helps mitigate a lot of these symptoms and the plyometrics as well. So just going briefly into some of the science behind it, essentially the heavy resistance training will help your bone mineral density, like I said already, because it just puts that multi-directional force on, and it really is important that we do this loaded. Again, there's always going to be a little asterisk mark at the end of what I'm saying, because we need to progress people from a certain level up to something else. But these are just some of the reasons why these forms of strength training make a difference. Increased joints and strength and stability. Dr. Pato alluded to ligament laxity. And so this is really, really key, to have the strength around and the stability around a joint. The high intensity interval training helps with that greater insulin sensitivity. And so the lack of, or the drop in estrogen, that flatlining of estrogen, essentially means that the slow kind of endurance work doesn't necessarily fire up the metabolism the way that you want to, and hence you have issues with the weight gain. And so the high intensity interval training does kind of mitigate that. Again, just to note that little asterisk that I'm going to come to in a bit. And obviously the plyometrics improves muscle power, which we lose from losing the estrogen. It helps with that mitochondrial function, which us endurance athletes need, and the improved transportation of glucose. So I just have to have this asterisk point here, because obviously if you're brand new and you're like Barbara and you're starting out from scratch and you've never done strength training, I really don't recommend that you start jumping and doing a whole bunch of box jumps and high intensity interval training. make sure that you take a graded approach and build up your strength. And so when I say do loaded exercise, I mean start with your body weight, because essentially we need to be able to move our body weight first and just build up so that you can avoid some kind of injuries from that perspective.
I just want to say one thing, Shona. I think it's really important for anyone to get the green light from their doctor just to make sure that there aren't any issues. I mean, if you haven't had a bone density test yet, and let's assume you haven't broken anything and then gotten one, you may not know the current state of your bone health before you embark on any of these exercises, and that's really important.
Yeah, definitely. And so Cecilia is asking that question essentially is, how do you strengthen your bones to avoid the osteoporosis or the breaking bones when you fall? And I mean, Barbara, in your experience, it was the strength work that made that difference for you in terms of helping with that bone mineral density?
Absolutely. In fact, I wrote an article just maybe about 2 years ago called A Tale of Two Falls, where I already told you about my first fall, where I actually did break my arm walking my dog. And then I embarked on this personal plan to keep my bones really where they are, because the truth is, without medication, you really can't reverse bone loss. You can reverse muscle loss, that we all know. You can build muscle back up pretty easily, but not bone density without medication. So my goal was to keep my bones where they were and not lose any more. And so that's when I embarked on my strength training plan. And I did very simple things. I'm not a gym goer, never have been. I prefer going out for my run and then coming back and doing my strength training now with Shona. But, just doing the basics. And that's all you really need. Push-ups and squats and, different variations of that. And some free weights if you like. And my all-time favorite, the plank.
Brilliant. I love that. But
I just wanted to add I just want to highlight two things. The first thing is what Barbara says is that you once it's started, you can't stop it, but you can slow it. And so it's really important what you do before you hit menopause and perimenopause. Yeah. And there's a lot that we can do to build our bone health. The younger we start, the better. So when I say younger, even around your ages of puberty and your reproductive years, it's a really vital and valuable years to be doing things to increase your bone health. So in other words, the kind of exercise that you're doing that does have some kind of impact, and certainly the diet that you eat that consume the appropriate amounts of calcium, and of course exposing yourself to natural vitamin D and other forms of vitamin D. But perhaps then to just address the question at hand is, what can you do once you've hit perimenopause and menopause? Medical interventions and non-medical interventions. So in terms of the medicines, as Barbara says, they won't reverse it, but what they can do is slow down the rate of bone loss. And there's a number of things, but bisphosphonates are commonly used. Supplementation with vitamin D might become necessary if you do have, of course, osteoporosis. And then diet becomes a really important source of some things like calcium. And you need to look for where you can get good and rich sources of calcium. But nutrition is going to be a topic that happens in a few weeks' time anyway.
Yes, so this was part of my plan too, was in partnership with my healthcare provider, incorporating vitamin D. My vitamin D level was checked. I had never had it checked before through blood work, and it was very low because you can get it from the sun, but many of us don't want to bake in the sun any longer, and that's very smart. We don't really want to do that because of skin cancer risks. And so all of that changed for me. More calcium, more vitamin D to help absorb the calcium, phosphate, magnesium. I mean, it's just all super, super important to put it all together. And consistency really is key. Don't be one of those people who says, oh, I'm going to embark on this new plan and then get bored with it and then go back to the way things were. Do not do that. Stick with it.
So I think with the nutrition aspect, we're not going to focus so much on the vitamin D and Doc Pato alluded to. There will be a full nutrition webinar not next week, the following Tuesday the 27th, of November. And so bring all those questions there. So I'm just going to allude a little bit because nutrition isn't my speciality. However, I have consulted our resident dietitian, Nikki, who will be with us. But again, it's vital for all of those things as mentioned there. And the two aspects I really just want to focus on is essentially protein and carbs. And, Caroline has asked the question here saying, should we be eating more protein post-menopause? And essentially it's post-menopause, it's perimenopause, it's for all of those reasons. And one of the reasons there, as I've said, is that protein with the exercise stress, that combination essentially extends your anabolic window to about 4 hours post-exercise. When I say anabolic, I mean that's your body's ability of building up. So obviously when you exercise, your body is breaking down. And so that combination with protein and the recovery from there allows for adaptation. And that combination is really, really vital. And people always say, well, I'll increase my protein intake, but at the expense of what? Because you can only eat so much. And I mean, I've said there's the suggested amount is 40 grams of protein with each meal, and then over and above snacks. And, sorry, I've made an error there. It should say feasible ? Because in reality, that might not be as feasible in terms of getting all of that in. However, and I'll touch on the timing of all of this a little bit in a few minutes, but it's not at the expense of something else. It's about contributing and timing that protein intake to make that. And again, Dr. Pato alluded to it, is the quality of the foods that you're eating. So we really recommend a leucine-based protein. And this is, examples are obviously your meat sources, milk, cheese, beans, seeds. Those are all really good forms of leucine-based protein. And then there is always the question around plant-based protein. And we generally don't have an issue with people who are plant-based. However, there is that you would need a higher protein intake from your plant-based sources to equivalent something that is a leucine base. And so that is really, really key to take into account. And I'm going to then focus on the timing, because yes, it's what we're taking, but the timing of that is completely vital. And so yes, you're going to have to adjust some of your meals, but really then try and take your protein sources around your training sessions, right? So 20 to 30 minutes post a session, and also ensure that what you're putting in before that session is key. We're used to take the concept is, we must take carbs in after exercise. So now add protein to that. And also when I spoke to Nikki about this, she did also mention that omega-3s for anti-inflammatory responses is really, really key. And I know there is a question about that, and I am going to touch on the cortisol concept now as well. And so lastly, just around this nutrition aspects and carbs. And, we've been talking about weight management. And so I know what's going to come up is because people will then say, well, I'm going to cut my carbs. And yes, the some carbs perhaps we see as bad, but essentially we have a cortisol increase post-training. That's natural. That happens. But if you are not having enough carbs, that cortisol increase is just going to continue. And the carbs will help that sort of level out again, and so that you don't go into this very high inflammatory response. The other thing that I want to touch on here is that if you are not having enough carbs and you're only increasing your protein intake, that you can go into a bit of a low energy availability. We touched on this in our last webinar around REDS, relative energy deficiency in sport, or syndrome. Sorry, I think I might have got that wrong, Doc. And again, I'm just going to park that because we're having a really, really in-depth conversation on this topic with Doc Patel and Dr. Kate Ackerman, who's from Boston. Sorry, I'm going to get that wrong. She's from Boston Med. Sorry, Doc, I'm going to mix that up. But so keep an eye out for that. But it's really, really key that when you're taking in your nutrition, that you don't find yourself within this low energy availability, because one of the things that can be as almost knock-on effects or side effects of low energy availability can be something like stress fractures. And if you already have this low bone mineral density, you're at far more risk. One of the aspects of REDS or REDS where it might be a trigger to see that you're sort of in a low energy availability is not having your period consistently. But if your hormones are fluctuating and you're not getting your period consistently, you might not pick that up. And so It's just something to really, really consider. And I watch your training load, because very often women get into this low energy availability by accident because they don't match their when their training load goes up, they don't necessarily match their intake. And so, yes, it's about protein. Yes, it's about carbs just as much, because if you're doing the right sort of exercise format, you're not necessarily going to be hitting on that weight gain aspect for me. So I know I've said a lot there, sorry, and I wanted to get all of that in. And if there are questions that are coming up, please. I think I've answered Glynis's question here, that is your body more prone to inflammation during menopause? Doc, do you want to answer that? I can follow on from you, but
sure.
you want to take that one
I
first?
did answer, I think, Glenn, in a message there, but essentially, yes, your body is more prone to inflammation. And I mentioned that, and I related it to increased inflammation in the joints, specifically in osteoarthritis. And I saw there was another comment around ankle pain. So it very well might be related, not from Glennis, but another one of our participants, that yes, due to a number of physiological processes, you could get subclinical inflammation, which can manifest as joint pain.
Yeah, good stuff. And so I think, Doc, your take-home messages here, and then I'm very keen to get stuck into a couple of questions for Barbara, yourself, and me. But yeah, maybe some take-home messages before we jump into the questions.
We are all runners in some shape or form that are sitting around this virtual table, and we know that in any race, we need to adapt our strategy to the specific race conditions, right? We don't run every single race the same. And in the same way, menopause is no different, right? Now, we've discussed the various symptoms of menopause and also acknowledged that they may influence your comfort before, during, and after training. It's really important to take note of your individual response, how you are experiencing perimenopause, menopause, and postmenopause, and then make changes that are necessary and suited to you and your lifestyle, you know. I also wanted to just, again, emphasize that there is no risk, and I'm generalizing here, of training during menopause. So we want to encourage you to keep training, but it's just really important to train smart. Barbara mentioned that, in fact, exercise is medicine, and it plays a really key role in alleviating many of the symptoms that are related to perimenopause and menopause. Train smart. It's not always about training hard, train smart. You need to choose your time. A lot of people commenting about the hot flashes, commenting that they also feel tired in the morning. So it might be that you need to make adjustments about when you train. And of course, if you are suffering from really bad hot flashes, where you train, so you might choose to go to an air-conditioned venue. You need to look at the kind of clothing that you wear, and you might want to invest in clothing that breathes easily, layered clothing that you can take off. And then finally, we've spoken a lot about nutrition, and it's such an important topic in the conversation of health and exercise, that there's a separate webinar being hosted on this, but really important that you are mindful and intentional when it comes to what you're putting into your body, essentially.
Yeah. Barbara, do you want to have any take-home message? I mean, we're not closing off. We're going to jump into some questions, but is there something that you want to finish off just from the presentation before we jump into the questions at all?
Absolutely. I do want to encourage people, even those who have been running for their whole lives or a few years, and those who are thinking about starting to run, as I did, as a way to mitigate some of these, things that are happening to our bodies with our bones and our weight and how we feel about ourselves and so on, heart health, brain health, is to look at the walk run program. As I mentioned earlier, I started by following the Jeff Galloway program, and I think he kind of popularized it. But Coach Parry is also a big fan of this for those who really would benefit from it. And I think that, it's something that people should really look at seriously. It doesn't necessarily have to compromise your time in a big way, your pace, but there are a lot of benefits, science-backed benefits to taking those walk breaks to help you, like me. My goal is to be able to run for the rest of my life. I have no intention of stopping. And I have to tell you, I've been running since 50, almost 14 years, and I have never had a running injury. Never. So yes,
there we go.
Exercise is medicine. Don't stop moving your body.
I love that.
Do not.
Yeah, and I think my take-home message essentially is, and again, we're not closing off, so hang around. We're going to dive into these questions, but this concept, and when you think about menopause and you think old, and I know Devlin, who's one of our guys, who's part of the team, and he's moderating, he'll tell me that I am old, and I'm going to laugh at him because he can't rebuttal this. But essentially, I don't want to think about that because I feel like I'm 27, but really I'm nearly 36. No, I almost said 37, 36. But really the take-home message for me is that I need to be doing these things now, because it doesn't mean that I'm getting old. It means I'm on my journey, and it means that whatever I do now is going to put me in a better place in 20 years. And I hope I can be running the way you are, Barbara, in years to come. So yeah, I love that. So let's take a couple questions. I am sort of scrolling through. Doc, I'm gonna ask you this one. It was related around heart rate, and I think you might have just touched on it, but how does menopause affect your heart rate when you're running?
It's probably in a number of ways, right? So firstly, remember, generally people hit menopause as they get older, and I mentioned that there's certain age-related changes that take place to the cardiovascular system, so structural and functional changes. And so men and women alike, assuming nothing else changes, what's likely going to happen is that your heart rate will increase as you age. Your resting heart rate will increase as you get older because of the various structural changes that happen to the lining of your endothelium and your vessels, as well as the heart itself. So your cardiac output decreases, your reserve capacity decreases, all of those things. So your heart basically needs to work harder in order to sustain a certain homeostasis. So just naturally, without menopause, your heart rate is likely going to increase. If you then think of some of the things that take place during menopause, like we said, you get these hot flashes for whatever reasons, and so your body will respond by wanting to make you sweat. Generally, when you're sweating, your heart is pumping faster so that you can get blood to the surface of your skin to cool it down. Your heart rate will then also increase in response to this. Your metabolic rate also slows down, and one of the consequences is that your heart rate will also increase. So generally, as you age, and also considering the symptoms and the effects of estrogen on the vasculature, the short answer would be that your resting heart rate is likely going to increase.
One of the ways the research that I've seen, one of the ways that can be addressed, also, I mean, that is a natural change, of course, but is the HIIT to really, speed up and slow down, and speed up and slow down in some ratio, and that really does seem to help.
Yeah, it does. And I wanted to follow on, Doc, as well, from what you were saying around the thermoregulation and how that's linked to the heart rate. And Lindsay actually had an interesting chat with Dr. Phil Maffetone the other day, and around how training in the heat, obviously your body's working quite hard to keep you cool. And so when you're training in the heat, that is then a very interesting topic for a menopausal woman, around training in the heat, already an elevated heart rate because you're trying to stay nice and cool, and now your thermoregulation is all out of whack from this hormone fluctuation. I mean, what would you say around that as well?
Are you asking me the question, Shona? I beg your pardon.
I was, but that's okay, Doc. It's fine.
Oh, yeah. I would be quite interested actually in having a look at some of the physiological studies, because obviously women who are entering menopause, who have got that hot flashes, have got an elevated core temperature. So I would have to just apply my mind a little bit to the physiological adaptations that would take place from a higher resting core to a higher external core temperature, if that makes sense, because obviously the adjustment is not that great, but I mean, that's I would have to look that up a little bit and apply my mind. Yeah.
No worries. Barbara, this is Millie. Millie's one of our members on the platform. She goes, who doesn't love the plank? So I just thought that was awesome to have that up there, just based on your comments.
Look, my husband, it's just so great. My husband and children know that I love, more than anything in the world, is to be efficient. And to me, the plank is the most efficient exercise one can do. Other than running, of course, but I mean, it works out every single part of your body if you do it correctly, and you have to do it correctly to make it work.
Yeah, there's a question that I saw, Jonah, around from Caroline, just asking for clarity around whether, she says, so you can't reverse bone loss, but you can increase density. Is that right? And so again, yes, we can't reverse what's taken place, and there are several medications that are on the market that can help increase your bone strength. One of the reasons that women take hormone replacement therapy is to replace estrogen that's lost after menopause, so that you preserve your bone density, right? So that's one of the reasons that women take it. There are risks and there are side effects of hormone replacement therapy that are beyond the scope of this particular conversation. And so other options that can preserve or increase your bone strength are, I mentioned this medication, bisphosphonates, just in terms of medical or pharmaceutical interventions that are commonly used. And then, of course, as we said, We spoke a little bit about some of the non-pharmaceutical or non-medical interventions that you can take, again, to preserve your bone health. We spoke about vitamin D supplementation, calcium, and definitely the kind of strength training and sort of high impact training that you can do.
Brilliant. There's a question here, and it doesn't have a name. It's from X. That's cool. We'll keep it anonymous. People talk a lot about strength training besides running, especially since aging women lose strength. Could swimming be considered a strength training, or do you have to go to the gym and carry weights, do the plank? We'll talk about the plank. But yeah, let me jump into that and just say, essentially you want to have some sort of load, and because swimming and cycling are essentially non-weight bearing, you definitely are not going to sort of get the response that you're looking for bone density, bone mineral density, and bone health. So while it's a great exercise, I wouldn't necessarily recommend it for a strength purpose completely, or for the benefit of what you need from a bone perspective. Even running in itself, and I mentioned that, running is great because it is that impact, but we still need that multi-directional sort of force. And when we say, lifting weights and doing resistance training, it doesn't necessarily mean going to the gym. And I'll say this because at Coach Perry, what we're doing is, it wasn't even because of COVID. We did this long before COVID. COVID can't even take recognition for this, but all our strength training is done at home. It's all home-based. It's kind of, you might just need a little bit of weight or some bands, because as Barbara mentioned, that weight is really, really great to have. So yeah, I'm not saying don't do swimming, because it is a great exercise to do and it'll complement your endurance training. But yeah, Barbara, your thoughts on that? I mean, you've done essentially loaded strength training, correct?
Yes, could not agree more with that. Swimming is great exercise, but it is not going to help your bone density. Really not. So you need to, as Shona was just saying, you need to incorporate true strength training into your mix. I have to tell you, I've become a real fan in the last year of the bands. And I have a set of the bands that I now use both around my ankles, like, following your classes, Shona, for, specifically for runners, the side walks, the monster walk, as they call it.
There we go.
Incredible. I mean, your body really feel something when you're done doing that. And of course, then you can just use the bands for upper body strength. They're efficient. Love that word. Very efficient.
Really encouraging to note.
And easy to carry.
Barbara Katz. Really encouraging to note, Shona, that of the people that answered the poll around strength training, 70% of them saying that they do a combination of resistance training and HIIT. But perhaps a little bit more concerning, that 20% don't do it at all. They say, who's got time for that? So perhaps some room for improvement.
You really have to, everyone. I mean, this is one of those things that you just have to do it. You just have to bite the bullet and just get with this particular program. I can't say that more clearly. I know that my colleagues here agree. It is one of those things, and it is not time consuming at all. And as we've been saying, it's one of those things you can do literally anywhere, anytime, right in your own home. Plug into Shona's and everybody's classes at Coach Perry. Do your own thing. Just do something. You know what I do? I'm a writer primarily, and I'm often at my computer. I take breaks at least every half hour. I aim for 20 minutes. And what do? I go off. I take a little walk around, get some water, and then I do, the plank.
The plank says either the plank or the band walks. Either
you get back to your desk to do some Kegel exercises, don't you, Barbara?
A couple of push-ups.
Yeah, Pat or Doc, you've got that right. Some Kegels in between that as well. So I think the time aspect is, we say, who nobody's got time for that. Essentially, we're going to be launching you do have time, and you must find time because it's that important. But in terms of making it easy, we are going to be launching a framework that is specifically for the menopausal runner. And part of that framework will be looking at, if it's taking a running session out and incorporating essentially 3 strength sessions and making them a little bit shorter, a little bit more higher intensity, so that it's specific to you, as opposed to just you have to do 4 running sessions and 3 strength sessions and be a mom and a wife and all of these things, so we need to we need to manage that. And so we are looking at ways in terms of making these frameworks easy for women to make this happen.
Jasmina saying she's going to start strength training. Goodness asking where she can do HIIT, and Millie saying even her osteopath suggested that strength training is definitely your best friend.
Yep, there we go. And so on the topic of strength, there's a question here from Glynis, and she's saying, I struggle with recovery after strength work. I'm in pain, like an inflammatory reaction. You know, what should I be doing differently? And obviously, Glynis, it's difficult to answer that question with just that piece of information. But one thing I would really consider is that your nutrition and that combination of the strength and the nutrition to ensure that because essentially the movements of exercise and strength work, it's breaking down the muscle fibers, you know, and so you have to have something that puts that back, and so that recovery is taking place. But again, you know, there might be other factors there. It might be how you sort of structuring your plan so that you're not necessarily doing sessions that are following on from each other. I mean, there are a lot of things there, but perhaps take a look at some of the nutrition that comes into that. Okay, so I mean, time flies when we're having fun. We've been going for an hour and 15 minutes, and I'm sure between the three of us we could continue this conversation for until I'm in postmenopause. So let's maybe, Doc, I'm not sure if you've spotted one or two questions that you might want to touch on, or that we can ask.
So
Barbara,
just
if there is anything.
one, I think Glynis asked around water retention, if this is associated with menopause, and the short answer is yes, it can be. That fluctuation and specifically the spike in estrogen may cause water retention and bloating. So that's very likely to be why you might be experiencing that. And then there was another question unrelated on intermittent fasting. So
I've got that one.
So I mean, again, looking at the polls, in fact, most of the participants complaining of weight gain and metabolic changes being their biggest concern or one of the biggest symptoms. And so I won't go into detail with this answer because, again, join the webinar in 2 weeks' time. But for those of you who don't know, intermittent fasting is basically an eating pattern, and you cycle between periods of fasting and periods of eating. It works for some people, but not for all. So, you know, intermittent fasting is a philosophy. They don't like to call it a diet, but rather an eating pattern. And there's different ways to do it. All right. You'd have to consult again a nutritionist or dietitian, but different people are different. All right. I can tell you now, for instance, for myself, it would never work. I'm a snacker. I'm one of those people who needs to eat regular small meals. Otherwise, my blood glucose just drops and I don't function well. But I do know that there's some people who respond very well to intermittent fasting and do successfully lose weight. The question then becomes, you know, how do you sustain it and how sustainable is it in the long term? I think if we want more detail on that, I'd suggest that you join Nikki, the dietitian, in a few weeks' time.
Yeah, I actually, Nikki and I actually spoke about this a little bit, and Doc, I think it's your point is exactly right. I think everyone is different and everyone will respond differently. The question is, you might lose weight. That's great. But what also is the effect then on your training and your performance? Because if we're talking about timing your meals around training, you know, so weight loss might not necessarily always be the goal. So I think I'm not confounding what you're saying at all, Doc. I just think consider that as well. You know, that what effect that might have. And Nikki actually mentioned a study around how intermittent fasting might be more specific to male physiology and essentially their utilization of carbs versus going into menopause and you know that insulin resistance and how that might not actually have such a good effect. But again, let me not get into that and we'll get Nikki to dive into that one in 2 weeks' time.
Just one thing I wanted to add to that conversation. I've tried intermittent fasting myself, and Doctor, I agree with you. It's not something that I could really keep as a sustainable thing. But when I do it, it's not a daily thing where I have that window where I eat on the window when I do not, as I have some friends who do to great success. For me, it was 5 days, once a month, and you know, very, very limited caloric intake. And that also worked too, based on, I did it for research for my last book. And based on blood work, it actually really was quite effective. It wasn't so much about weight loss. It was more about a growth hormone. But one thing I just wanted to point out, all of these things to me are all tied together in one neat little package that I've written about. And to me, it makes sense. I like to make sense of complicated things. And it's all a jolt. Sometimes a jolt to the body actually does good things. To me, intermittent fasting is a jolt to your system, for example. Doing jumping jacks is a physical jolt to your body, and it can do very good, assuming you don't have osteoporosis already. Let's assume that your bones are good and strong, and you can do these things. So there are certain things, even putting your body or even just your face in ice cold water jolts your body, but the result is a very positive thing. It fights inflammation and the like. So it's an interesting idea when you're thinking about all these things, to think about ways that you can safely, I'm not talking about crazy jolting, safely jolt your body sometimes to maybe even kickstart the program.
Yeah, definitely. Thanks, Barbara. Doc, there's a question here. I scrolled all the way down to the beginning from Katie, and I know we're not talking essentially the therapeutic the hormone replacements and so on, but I think it's a good question, because Katie's asking, if estrogen has such a big effect, should we be replacing it? And maybe if you can just, I know we didn't really want to focus on that, but I thought this was a good question. Could you maybe give us some insight to that?
So absolutely. Remember, menopause, perimenopause is all a natural process. So naturally, at some point, we are designed so that our estrogen levels will drop, all right? In terms of our reproductive timelines or cycle as females. So it's a natural phenomenon. The reason that we would replace it would be if we are experiencing symptoms that are really just influencing our quality of life such that it's debilitating, then you would want to consider very low doses of estrogen to just help manage it or lessen the severity of those symptoms. And also, really importantly, the other very important reason why we might consider replacing estrogen is because of the bone health, which we've spoken to in a fair amount of detail. And again, that would be very low doses, and you'd have to be mindful of the side effects. There are known and well-established side effects, and specifically increased risk of certain cancers, right, and endometrial cancers. And this is why, and as well as increased risk of certain cardiovascular complications, right, and cardiovascular disease. And this is why there's a lot of caution before prescribing. So one would have to first analyze the risk factors of that specific individuals. If they are at increased risk of these certain cancers, if they are at increased risk of cardiovascular disease, then you wouldn't encourage estrogen as a replacement therapy. You would use one of the many others, one of the other sort of medications. Now I'm assuming that your symptoms are quite severe. One of the many other medications that I've mentioned or listed in that slide. If you're worried about bone health, you might use bisphosphonates. If you're worried about the hot flashes, you might use your bioidentical products. You might use even things like antidepressants. So certain antidepressants might help with the hot flashes and other symptoms. And so it's important at a certain period of our lives in terms of our reproductive health. This is estrogen. And in terms of bone density, but after a certain period, naturally women aren't supposed to have children anymore, and therefore it is supposed to cut down. The issue is, what is the effect as we're going through that transition and afterwards, and how do we best manage the symptoms so that we don't compromise on our quality of life? Estrogen or hormone replacement might be one way, but there might be indications for you to use other medications which might be safer in your particular case.
Right, and just to add to that, new research is showing that HT actually can benefit women's brain health. And that's something else I think. I know we're talking about exercise and fitness and strength training, but that's important to point out too. And no, and it isn't for everyone. And there could be some family history, there could be some genetic issue going on with you. It's not for everyone. And that's why you have to have a partnership with your primary healthcare provider. Discuss that.
Yeah, 100%. I mean, one of the things that I learned just through, doing some of these courses, I recently did a course with Dr. Stacey Sims, where I think you might have seen some reference down there. But one of the things that she mentioned is essentially, Doc, and correct me if I'm wrong, but the hormone replacement, so that estrogen that has been developed essentially in a laboratory will never really, they got it as close as they probably can to the molecule of to estrogen, but they can never really replicate the same effect that the natural hormone can. So while it might mitigate one or two symptoms, it really can't have that sort of chemical effect that the natural hormone does. And I think your points around being natural and that process is quite pertinent there. So, okay, I think Doc, unless you see any questions, or Barbara, if you have any questions that you wanted to answer, I think we might call this. I mean, I'm getting a couple of responses here. Kay is saying, thank you very much. I've learned a lot, and it's good to find that we're all going through this and the same sort of experiences, and that it's totally normal. Yeah, I think there's been a lot of good feedback. I haven't seen the chats. I've just been looking at the questions. But anything else, Doc, from your side that you want to touch on before we close off, or your
No, I'm
parting
comfortable
words?
that we have delved into the topic with enough sort of robustness, and really thankful for the honesty and the candid nature of the questions that came out. I think it's always fantastic when you can address real issues for real people. So I think my take-home message really would be, remember, this is, in fact, I'm going to steal from you, Barbara, all roads lead to menopause, or perimenopause ultimately. And so for the 33% of you who are not yet at that stage, you must think about what you can do now to best protect yourself or to optimize your health so that you can navigate that phase with better ease. And for those of you who are going through it or have already gone through it, there's still a lot that you can do, of course, to optimize your current state of health and your level of performance. And exercise is medicine.
Brilliant. Thank you, Doc, and thank you for your time. Barbara, your closing words and final sort of send home message.
Yeah, I want to thank everyone for joining in. I mean, this means that you have a real interest in taking control of your life starting today and going forward, and that's really important. One thing I would like to ask all of you, I did say early on in this conversation that menopause is still considered a taboo topic. And I think I think we can all agree that's insane. This is a natural, normal occurrence that happens to every woman, and it's ridiculous that we don't talk about it more openly, not only among each, with ourselves, with our peers, our friends, but with our healthcare providers, with our partners, with our children, and in the workplace. Now, I have to say, being an American, I have to applaud my girlfriends over and everybody over in the UK. I feel that they are much more enlightened about menopause. I see a lot more websites devoted to menopause. I just saw that the UK school system has now incorporated menopause into education, menopause education, into the curriculum, which is outstanding. So I just feel that we need to be the leaders here. We talk about it, and the more everyone sees how comfortable we are talking about it, the more comfortable and open everybody else will be. Thank you.
Yep. I love that, and thank you, Barbara, for your time. I mean, that was essentially going to be my parting shot as well, is around normalizing this conversation. I mean, we as a Coach Perry team, maybe not to throw this out there, but I'm the only female on the team, or bar that we've actually just hired another female, yay for that. But it's a team of some guy coaches, and we sat very openly today and had this conversation around menopause. Recently, we've had some conversations around periods. I mean, Brad joked the other day, he said he's never spoken about periods as much as in his entire life. But exactly that. It's about normalizing these conversations, that it's not taboo, that we can have it, and so that young athletes don't necessarily need to be having the struggles that we and you have had. And so let's continue this conversation. Let's keep normalizing it. Let's make sure that this is moving forward. And so, yeah, thank you all for joining. We did put up the YouTube channel there, so please be sure to subscribe to that. There probably will be a replay of this going out, and be sure to tune into next week, because we're going to have Dr. Patso and Dr. Kate Ackerman, specialists within women's health, and focusing on the REDS discussion, the RED-S discussion, and then, as we mentioned, in 2 weeks' time, the discussion with Nikki, and focusing around nutrition and all things nutrition. So REDS discussion, menopause, as well as general female cycles and that sort of concept. So, and at Coach Perry, obviously, we are looking to have these conversations. So keep an eye out for that with our YouTube channel. And essentially, thank you so much to my guests, or my panel, for joining tonight. Really, really, really appreciate your inputs, your expertise, and your time. And we'll chat to everyone soon. Thank you very much.
See you on the road, everyone.
Thank you.
Bye. Thanks.